All right, everybody, good morning again. Josh here with Dr. Harrington, moving forward with the altered mental status review lectures here. Next topic, stroke. Very broad topic in emergency medicine, but for test-taking purposes, we'll focus on really the bread and butter of strokes and what are the most likely test questions that you'll see coming through to get these answers right. So pathophysiology, a lot of like most common cause questions always pop up. So for ischemic stroke, if the person's greater than 50 years of age, atherosclerosis would be the most common cause. If they're young, less than 50, looking for some sort of hypercoagulable state. If it's a hemorrhagic stroke, by far, very common question, subarachnoid hemorrhage from a ruptured Barry aneurysm is what they're looking for. As far as stroke syndromes go, there are loads of different vessels that can be involved. We're going to hit the most common ones that we see in these Q banks, starting with middle cerebral artery. So this is the most common affected vessel. Usually presents with a contralateral paralysis. Typically the upper extremities are more involved than the lower extremities, and they're sometimes they'll include some sort of aphasia in with this test question, and then then they can ask what artery is involved in this stroke. It'd be the middle cerebral artery. Next one, moving down, would be the anterior cerebral artery. Again, it's the medial portion of the brain. Typically presents with some sort of frontal lobe dysfunction. You get an apraxia or sort of like a clumsiness type presentation, and you get this contralateral paralysis where the lower extremities are more involved than the upper extremities. Looking again for what's the most common artery involved? Anterior cerebral artery. Next question, thank you. Mm-hmm. Posterior cerebral arteries, really the big things that I always focus on this one is some sort of visual complaint, ataxia, nausea, vomiting, something to that effect that will push you to the back of the brain to get these questions right. Again, posterior cerebral artery, think some sort of ataxia, visual complaint, nausea, vomiting. Sometimes you get like a loss of consciousness with that as well.
Mm-hmm. Yeah, and visual complaints really is going to be the big distinguishing factor of this stroke, particularly in test questions. It's hard to write a test question on a posterior circulation stroke that doesn't involve visual acuity or then the cranial nerve palsy.
Yeah. Next one, I think we all remember from medical school is like, man, it has to be like the worst diagnosis. Basal artery strokes. This is the quadriplegic, the locked-in syndrome. So again, you're presenting. Some questions stem down that pathway. Some sort of loss of all motor function. They have upward gaze on exam. This is a concern for what type of stroke, and the basal artery is affected here. The next ones that come in are lacunar infarc. So there's a myriad or loads of different strokes that can happen in this part of the brain. The most common ones that we see in test questions are the ones that you can easily ask a question on. So if it's a pure sensory type deficit, think of the thalamus, and if it's pure motor, think pons or internal capsule. Beyond that, there's loads of different other strokes that can occur, but then it kind of muddies the water up a little bit, and so these ones are really two easy ones that you can write a test question on and get the answer right.
The other thing I think when you get into any of these, there's going to be a lot of what's the next best step. Really in this area, what we're typically looking for bleeds in here. We'll get to it in a moment, but if they give you that pure sensory or pure motor, then kind of be thinking your next step is going to be a CT to rule out a bleed. These aren't really amenable to a lot of therapies so well. So what you really want to make sure is that we're not going to have to do anything else.
Absolutely.
But again, we'll cover kind of more of that here in a minute.
Yeah. Let's say we get the CT scan, comes back with a hemorrhagic stroke. Most common here will be the subarachnoid hemorrhage. This one I think we're all familiar with, right? The sudden onset headache, the worst headache of my life. A 6-year-old female comes in, sudden onset headache, and then, what is this likely from? Rupture of a Barry aneurysm. And then management comes into play. And there's a lot of controversy between how this is worked out, but for test-taking purposes, we'll make it real simple. First one you do is obviously that CT scan looking for a hemorrhagic stroke. If it's less than 6 hours, that's where it's most sensitive, and it could read that way as well. You have evidence of a stroke on examination. CT scan is obtained, less than 6 hours onset, and this is what you see. Or it could be, CT scan appears normal, and you're still concerned for some sort of intracranial hemorrhage. What's the next best step? And you're looking for that LP.
Well, and hold on. Before we do, how do we do the? do the thing.
Oh, yeah.
Yeah. Let's laser pointer this because I think this is something, if you're not familiar, back here, this black coloration is what you really would expect to see up in here and here and here. So that white right there, this white right around here, it's just faintly outlining the midbrain there. That's all blood. So realize when you look at these, white in those areas is consistent with a subarachnoid hemorrhage. Sometimes those can be subtle. On testing, it really should be fairly obvious. So they should give you something like this that's got a substantial amount of white.
Absolutely. Yeah.
Anyway, so moving on, we'll assume it's negative, and then what's the next step?
Yeah. So here we're going into the lumbar puncture here. So CT scan, so symptoms happen, more than 6 hours after onset. You get that lumbar puncture, and what you're looking for is those red blood cells don't clear as things progress. With a lumbar puncture, there's always the red blood cells and there's xanthochromia, and the time difference is important here. So if it's within that like that 12-hour mark, you'll see those red blood cells and they won't clear as the test tubes are drawn. Versus it's a couple days ago or so, then you start seeing the xanthochromia develop, and so it becomes a time purpose here where you might be looking for xanthochromia, but that's within the 12-hour, it's like upwards of 2-week mark, versus anywhere before that we're looking for the red blood cells.
So I think the big three that you think about here that they could hypothetically throw at you is, one, you've got a normal CT scan, you do a lumbar puncture, and you've got red blood cells in the first tube, which progressively clear by tube 4. That's a traumatic tap.
Right.
Your second alternative is that you've got red blood cells that don't clear from tube 1 to tube 4, and that indicates an acute subarachnoid hemorrhage. Or you've got either presence of xanthochromia, or they'll mention that you're several days out from the worst headache of life, or they had like a sentinel bleed and they've got a recurrent headache now. So initial bleed that was small, bigger bleed now, and you've got xanthochromia. Like you said, that can be up to 2 weeks, and that indicates a previous subarachnoid hemorrhage. So when you get lumbar puncture findings, that's how you're going to think of your three different presentations of spinal fluid that you're looking at.
Awesome. So CT scan within 6 hours, see the bleed. You've made your diagnosis. If normal, move down to the lumbar puncture.
Yep.
Look for the red blood cells that persist through the
four tubes.
The 4 tubes.
Or xanthochromia. If you see that, next step is that CT angiography, looking for the berry aneurysm.
Where's it coming from? The berry aneurysm. Nice. Okay, next one would be like a hypertensive intracerebral hemorrhage. Usually you get some sort of picture over here. So again, there's that white uptake there, indicative of that bleeding that's going on.
And to be clear, this is a non-contrast head CT. So acute bleeding is whitish on a non-contrast CT.
Yeah. Questions I've seen on this one is, most common cause or most common area of where hypertensive intracerebral hemorrhage would be, and it's the putamen. And it's almost the putamen is there and exists to bleed in this situation. And so, if you get, where is it? Putamen, thalamus, pons, whatever it is, it's the putamen. Typically present with some sort of, next step would be like a cerebellar hemorrhage. So again, you're looking for an occipital headache, ataxia, dizziness. And if it's a pontine hemorrhage, the classic correlation with that is the pinpoint pontine pupils. And so if you have a CT scan there where you're seeing evidence of an intracerebral hemorrhage, there's pinpoint pupils. Think pontine in location.
Mm-hmm. Yeah, and that's I always like to make the point on these pinpoint pupils. So you think about your differential. So if you get a question stem that mentions pinpoint pupils, there's really only a few things that are going to cause this. So you've got narcotic overdoses that'll cause pinpoint pupils. You've got your cholinergic toxicity, which you really expect to see if cholinergic syndrome, toxidrome, associated with that. Clonidine can do it. And then pontine hemorrhages. So there's a pretty short list. If you see it, that's a really good clue, and it narrows down what you need to be thinking about.
That's awesome. You could even start the question stem with, patient with this on physical exam, pinpoint pupils.
Yeah.
And then you can take it the opposite direction and look for toxidroma type state versus do I need to get a CT scan and look for an intracerebral hemorrhage.
Yep.
Nice. Okay, next up would be treatment of these wings. So treatment does vary, right? If it's an ischemic versus a hemorrhagic stroke. So the treatment of ischemic strokes, really what we're pushing for is thrombolytics on this pathway here. So if their blood pressure is less than 180, over 105, and these are good numbers to know, then you can become a thrombolytic candidate there. If not, then we need to be treating systolic blood pressures that are greater than that to get them under that range. If it's a hemorrhagic, goal is a systolic blood pressure less than 140. Classically, usually a question, some sort of 60-year-old male comes in, there's evidence of intracerebral hemorrhage on examination. Which of the following, also, correlates with cerebral vasoconstriction, and it'll be nicardipine. And they'll have a whole slew of different medicines to choose from, and it'll be nicardipine or nimodipine, some sort of pine.
I've consistently seen nicardipine, and this is one of the few times I'd say I think it's just worth knowing the medication.
Yeah.
Just know nicardipine for a head bleed.
Yeah. Nicardipine, cerebral vasoconstriction, brain bleed.
Yep.
Thrombolytics, again, very controversial topic. Is for test taking purposes. You got to make it real easy so these questions can make sense. When you're considering thrombolytics for an ischemic stroke, the inclusion criteria is very simple. So anyone that's greater than 18 years of age, you've got an ischemic stroke with some measurable neurologic deficit. They might give you like an NIH scale score on there. And then the onset of symptoms is going to be within that time period. So that less than that 4.5 hour mark is what we're looking for. In real life, just about all of us pull up all of the exclusion criteria for TPA as far as are you a candidate or not. But obviously you can't do that on a test. But the test also isn't going to choose some of those less well-known ones. And so these are the ones that I typically remember that are easy to remember as far as are you a TPA candidate or are you not? So if you're bleeding in your head, obviously we don't want to give TPA. So any sort of head trauma or a stroke within the last 3 months makes sense. You're not going to give TPA. If you've ever had a history of an intracerebral hemorrhage before, not a candidate. If there's a tumor, if there's an AVM, if they know they have an aneurysm, if their blood pressure is elevated, if they're on anticoagulants already, if their INR is abnormal, then that excludes them from TPA. That's typically the most common ones that I've seen on a test taking question stem. When they're getting to TPA, yes or no.
And given how complicated this is and the fact that I think we all realize none of us memorize this, basically if they give you the possibility this person could be bleeding, they really should be giving you kind of a softball on this one. They clearly don't give them something to make them bleed more. So
absolutely,
I wouldn't belabor this. Just be generally familiar with it.
Perfect. And then lastly, to round things off, if they're not a TPA candidate, aspirin is the right choice. It needs to be done within 48 hours. All right, and that's all. High yield stuff for strokes. Thanks, guys.